Hello, everyone. I'm a doctor from Sichuan Provincial Maternity and Child Health Care Hospital in Chengdu, China. My Chinese name is Zhang Yong. So, first of all, thanks for the invitation. My speech is application of other comprehensive rehabilitation intervention in preterm infants in NICU. As we know, the birth rate and the survival rate of preterm infants has gradually increased. However, the short-term and long-term prognosis of premature infants is not promising, especially very premature infants and very low birth weight babies have a high incidence of neurological disability. We know cerebral palsy, motor disturbance, cognitive, attentional, behavioral, socialization disturbance occur in some premature infants. And with a likelihood of problems with visual and hearing impairments. We know rehabilitation treatment is an important way to improve premature infants' prognosis. For example, early oral motor function intervention, early sound contact, and music therapy, neuromotor and oral motor function are beneficial for premature infants. And a private study proposed combined rehabilitation, including Bobby's method, ultrasonic therapy devices, tracheal talus, electric stimulators, and nutritive nerve drugs, and family intervention. But the specific program has not yet been unified. We advocate earlier combined rehabilitation intervention. So here we introduce the concept of our earlier combined rehabilitation intervention. It includes visual, auditory, oral motor, respiratory function, and neuromotor function intervention to explore the clinical effect of other combined rehabilitation intervention on premature infants in the NICU. This study was conducted in the NICU of the neonatology department of our hospital. It was reviewed and approved by the hospital's medical ethics committee. The inclusion criteria were gestational age less than 32 weeks, birth weight less than 1500 g, and consent by the parents for the infants to undergo the intervention. And the exclusion criteria were congenital malformation, genetic metabolic disease, severe asphyxia, and lack of consent by the parents. According to whether their parents agreed to carry out intervention, premature infants included in the study were divided into an intervention group and a control group. All infants received the current routine treatment based on the clinical guidelines. And the intervention group was additionally treated by visual and auditory stimulation, oral motor function, respiratory function, and neural development training. We began the intervention when the infants had stable respiration and oxyhemoglobin saturation under non-invasive ventilation and ended at discharge. Professional trained physical therapists in our hospital evaluated and implemented the treatment. The frequency is once a day, and the total time is approximately 20 to 25 minutes. During the whole treatment process, vital signs were monitored. If the signs were not stabilized, we would stop immediately. For visual and auditory intervention, reed balls were used to gently shake the infant's eye to attract attention and stimulate the child's tracking ability. In the whole therapy, music was applied to stimulate the children's tracking and hearing ability. The total time approximately 20 to 25 minutes. For respiratory intervention, and it includes 3 steps. First, with a cotton swab to stimulate the patient's chest breathing according to the mask group and stimulate a spontaneous breathing response for 5 minutes. Secondly, chest compressing and vibration techniques were used to prevent the collapse of the tracheal and the bronchus and maintain tension of the tube wall for 5 minutes. Third, therapist touches and massages the child's limbs, face, chest, abdomen, stimulate the development of the baby's original reflex and mask time for 5 minutes. For neuromotor intervention, Bobbies and Viator were used to train the infants for 10 minutes. For oral motor intervention, include oral stimulation, non-nutritive sucking, and oral support. A cotton swab is moistened with normal saline, were used to wipe the skin from the outer cheek to the root of the ear. the area between the nose and the upper lip, the inner cheek side of the mouth, and the upper and the lower gums and the lips, forming a circle shape. Circle shape. A larger cotton swab was used to stimulate the tongue and the lower part of the tongue, promote the tip of the tongue, to stick out of the mouth, lift the tongue several times, and press lightly and stimulate the front of the ear and the cheek with the hand for 2 to 3 minutes. Then we evaluated the infants with clinic data, Sliverman school scar, Ballard school, and NBNI scar. Clinic data included the duration of oxygen supplementation during gastric tubules, common complication of preterm infants such as ROP, NEC, BPD, intracranial hemorrhage, etc., and the days of hospitalization. Sliverman school scar include 5 aspects: upper chest movement, lower chest movement, the forehead depression, nose instigation, and groaning during exhalation. Scores of 0 to 3 means no or slight breathlessness, and 4 to 6 means moderate breathlessness, and 7 to 10 means severe dyspnea. And the lower the score was, the less dyspnea there would be. Ballard score included behavioral ability, response to readable and sound, mask time, preemptive reflex, and the posture. The higher the neuromuscular score was, the better development would be. NBNI scar performed in a quiet semi-dark room until a temperature of 24 to 26, 1 hour after breastfeeding, when the babies got their postmenstrual age, 40 weeks. The total inspection time was 20 minutes, and score less than 35 points indicated brain injury, and 35 to 36 points indicated suspected brain injury. Then we got the results. From this table, we can find there was no difference in sex, birth weight, gestational age, and the start time of the intervention between the intervention group and the control group. From table 2, we can find the time of invasive ventilation before starting intervention was not difference between the 2 groups, but the duration of oxygen oxygen supplementation, the duration of induced gastric tube use, and the death of hospitalization in the intervention group was shorter than that in the control group. Just here. Yeah. From this data, we can find the incidence of ROP, BPD, and NEC in the intervention group, where nor that in the control group. But the incidence of intracranial hemorrhage was not significant difference between the two groups here. Here we can say about NBNI school, there was no significant difference between the two groups, but further statistical analysis shown the difference was statistical significant. And table 5 shown us the Sliverman school of two groups and a different time were significantly different. And there was an interaction between the test time and the group. At the beginning of the intervention, it was a low significant difference between the two groups. With the passage of the time, the Sliverman school gradually decreased. The school of the intervention group in the first week, the second week, the third week, were all lower than those of the control group. That is, the dyspnea of the intervention group was lower than that of the control group. From this table, we can get the standard school analysis of the two groups and different time were significantly different. And there was an interaction between the test time and the groups. And at the beginning of the interaction, there was low significant difference between the two groups. As time went by, the Ballard neuromuscular school gradually increased. The scores of the intervention group in the first week, second week, and the third week were higher than those of the control group. That is, the muscle development in the intervention group was better than that in the control group. So we can get the conclusion from above findings. Earlier combined rehabilitation intervention can improve the short-term clinical outcomes of premature infants. Certainly, this study has limitations. It is a single-center study with a small sample size, and evaluated only relevant indicators during hospitalization. So to further confirm our short-term results and long-term prognosis of premature infants. We need to expand and sample size, expand the sample size and closely follow up the discharged premature infants for further evaluation. That's all for my speech. Thank you for listening.